Hello everyone. Today's lecture is on the interpretation of the electrocardiogram, or ECG. My objectives for this lecture are for you to be able to first learn how to perform an ECG, to learn how to measure times and voltages on the ECG, to learn the different waves, segments, and intervals, and their normal ranges, to understand the structure of the heart's electrical conduction system, to learn the steps needed to read a complete ECG, to learn the different tachyarrhythmias and how to recognize them, to understand the concepts of axis and the R-wave progression, to recognize patterns that are consistent with heart blocks and chamber hypertrophy or enlargement, to recognize patterns consistent with myocardial infarction, and to interpret the... Hello everyone. Today's lecture will be on the interpretation of the electrocardiogram, or ECG. My objectives for this talk are for you to be able to first learn how to perform an ECG, to learn how to measure times and voltages on the ECG, to learn the different waves, segments, and intervals and their normal ranges, to understand the structure of the heart's electrical conduction system, to practice the steps needed to read a complete ECG, to learn about the various tachyarrhythmias and how to recognize them, to understand the concepts of R-wave, progression, and axis, to recognize patterns consistent with heart blocks and chamber hypertrophy or enlargement, to recognize the patterns suggestive of a myocardial infarction or MI, to interpret the QT interval, and to recognize the common patterns suggestive of dangerous hyperkalemia and pulmonary embolism. Starting with just performing an ECG on your own. Hello everyone and welcome. Today's lecture will be on the interpretation of the electrocardiogram, or ECG. My objectives for this lecture are for you to... Hello everyone and welcome. Today's lecture will be on the interpretation of the electrocardiogram, or ECG. My objectives for this lecture are for you to be able to first learn how to perform an ECG, to learn how to measure time and voltages on the ECG, to learn the different wave segments and intervals and their normal ranges, to understand the basic structure of the heart's electrical conduction system, to practice the steps needed to read an ECG, to learn about the various tachyarrhythmias and how to recognize them, to understand the concepts of axis and R-wave progression, to recognize the patterns consistent with heart blocks and chamber hypertrophy or enlargement, to recognize patterns consistent with a myocardial infarction or MI, to interpret the QT interval, and to recognize common patterns consistent with severe hyperkalemia and a pulmonary embolism. Starting with how to perform an ECG on your patient, a common ECG machine will have 10 wires coming out of it. These are called the electrodes, and you're going to be positioning them on your patient in specific ways. Starting off, you have 4 electrodes that are going to go on the patient's limbs, the right arm, left arm, the right leg, and the left leg. These don't actually have to go directly on the patient's limbs. They can go closer to the chest wall, as shown in the diagram here. And that's usually what I do, since the limbs can be vibrating and this can affect the reading of the ECG, causing artifacts. And in addition to these 4, there are the 6 precordial electrodes, V1 through V6. And they're positioned as shown here in the diagram. You start at the 4th intercostal space, right sternal border, that's V1. Then 4th intercostal space on the left sternal border, that's V2. Then for V4, skipping over to that one, you're going to jump down to the 5th intercostal space at the mid-clavicular line. And then V3 will go between V2 and V4. V6 will go at the left anterior axillary line, at the 5th intercostal space, and V5 will go between those. Now, it's important to know how to position these electrodes properly, because if they're not positioned, that can cause artifacts and lead to improper interpretation of the ECG. So one common error is that the left and right arms get flipped, usually because of the improper labeling of the electrodes. And the most common way you'll see this is if you look in lead 1, you see inversion of the QRS and P waves. The other common error that we'll see is people might position the precordial leads too high. So they'll put V1 up here, V2 up here, and maybe follow it along like this. And the consequence of that is the voltages in the precordial leads will be way too low, and that can lead to interpretation of that as a possible anterior infarct or low ejection fraction. Now, sometimes we, in addition to this pattern of positioning the electrodes, we also have, in cases when we suspect a right-sided infarct, right-sided MI, we can get right-sided ECGs as well. So instead of positioning V3 to V6 on the left side, we can flip everything over. So position V3 on the same spot, but in its mirror image on the right, V4 on its mirror image on the right, V5 on its mirror image, and so forth. Okay. Moving on, we'll talk about the calibration of the ECG, so measuring times and voltages. As you see here, essentially the ECG is a graph of voltage over time, read from different portions of the heart. So as far as the y-axis, that's voltage, and you see that the ECG is divided up into little boxes. Here's a little box here. That's 1 millimeter across, 1 millimeter wide, 1 millimeter high. And then you have these bigger boxes, which are made up of 5 little boxes across and 5 little boxes high. So that's 5 millimeters on each side. So the voltage calibration in a standard ECG is that 10 millimeters, or 2 big boxes, will correspond to 1 millivolt. And you can usually see that on every ECG, you'll see one of these square waves, and that's telling you exactly how much 1 millivolt is. And in this case, it's exactly 10 little boxes, or 2 big boxes, and that's 1 millivolt. This is important because if you want to magnify things, you're not able to see all the waves and points on the ECG properly. You can magnify it by increasing the sensitivity. So instead of making it 10 millimeters per millivolt, you can make it 20 millimeters per millivolt. Now on the x-axis, we're measuring time. So the standard calibration here is that the ECG paper moves through the machine at a rate of 25 millimeters per second. And so if you do the math, 1,000 milliseconds in a second, 1 second, that means that every one little box is 40 milliseconds, and every big box is 200 milliseconds. Again, just like with the voltage, you can change the calibration. You can increase the rate at which the paper's fed through the machine to artificially slow down or speed up the rhythm. Moving on to the wave segments and intervals that we commonly see on the ECG. The major ones are going to be the P wave, the QRS complex, and the T wave. So waves are just referring to the major upward or downward deflections from the baseline. P wave representing atrial depolarization. The Q, R, and S waves, collectively referred to as the QRS complex, represent ventricular depolarization, and the T wave is the ventricular repolarization. The segments are the flat lines that appear between the waves. So you'll have, for example, your ST segment, which is from the end of the QRS complex to the start of the T wave, and the PR segment, which is from the end of the P wave to the start of the QRS complex. And then intervals these just refer to the time between any 2 points. So that could just be an entire wave. So like you could talk about the QRS interval. That's just the width of the QRS complex. Or you can talk about the QT interval, which is from the start of the QRS complex to the end of the T wave. And here's a nice diagram showing the labeling of all of these intervals and points and segments. We'll pay particular attention to the TP interval here. So in this case, there's a U wave here. But a lot of patients don't have that normally. If they didn't have it, it would be completely flat, and we could call it the TP segment. And that's important because that's the electrical baseline of the heart. So anytime we talk about ST elevations, we're measuring from that TP to the start of that ST segment. Or if you talk about PR depressions, same thing. We're talking about the distance from the TP segment to the start of the PR segment. Moving on to the electrical conduction system of the heart. So the basic concept is that there's several clusters of electrically excitable pacemaker cells in the heart, and the most important ones are located in the sinoatrial node up here in the upper part of the right atrium. There's another bundle of them in the atrioventricular node near the center of the heart, and there are also many spread throughout the rest of the heart in the atrium and ventricles, which are essentially there to take over if any of the other ones fail. Usually you have an impulse starting from the sinus node, and the signals are conducted to the AV node through various specialized pathways. There's 3 in the right atrium: the anterior tract, the middle tract, and the posterior tract. And the left atrium gets depolarized through a special side pathway. It's called Bachmann's bundle. So the left atrium actually depolarizes slightly slower than the right atrium. From the AV node, there's a structure called a bundle of His, and then that branches off into the right bundle branch and the left bundle branch. And these depolarize the right ventricle and left ventricle respectively. Now the left bundle branch has its own special set of branches, the septal branches, a left anterior fascicle and a left posterior fascicle, and we'll see how that plays into pathology later on in this lecture. Next we can talk about the different lead anatomies. Now remember I talked before about the 10 electrodes that go into performing in a proper ECG, and these 10 electrodes are going to translate into 12 different leads, which are essentially different views that you're getting of the heart wall. And to appreciate how these leads are grouped together, I have a couple of pictures here. So this is a view of the heart in the frontal plane up here, and this is a view of the heart in the coronal plane. And you can see up on the top in the frontal plane the limb leads. So starting with 1, 2, 3, AVL, AVF, and AVR. And they're each looking at the heart from a different angle. So, for example, 1 is looking at the heart from this direction, 2 is looking from this direction, and AVF is looking from this direction. And in the same way, the precordial leads look at different walls of the heart, but from the coronal plane. So you have V6 looking at the heart from this direction. And once you understand this concept, you can see how we can group the leads together to get different anatomical views of the heart. So this lateral wall of the heart, left lateral wall, it's closest to the leads 1 and AVL in the frontal plane, and it's closest to the leads V5 and V6 in the coronal plane. So that's why we say that the lateral wall is associated with the leads 1, AVL, V5, and V6. Similarly, the apex of the heart is close to leads V2, V3, V4, and V5 in the coronal plane, and so abnormalities in the apex of the heart will show up in those leads. Now here's an ECG from a patient at our hospital, and before even looking at any of the different waves and segments on the page itself, I would pay attention to the corner, the left lower corner of the page, where you see the calibration listed here. Again, 25 millimeters per second on the x-axis, 10 millimeters per millivolt on the y-axis. And it's important because your interpretation of this would very much change depending on what these numbers were. So if the speed of the paper, 25 millimeters per second, if it were different, then the same ECG could either represent a bradycardia or a tachycardia. But unless you actually knew what the speed of the paper was, you wouldn't be able to make that determination. So the steps I usually go through when reading ECG, like I said, first I start with checking the calibration. Then I try to figure out the rhythm, and I specifically will look at leads 2 and V1, because this is where you see the best P waves most clearly. And to decide what the rhythm is, I'm going to have to look at a few things simultaneously. So that would be the rate, the width of the QRS, whether it's wide or narrow, is the rhythm regular or irregular, what do the P waves look like, and what are the atrial activity that's showing up on the ECG, and what is the relationship of the P waves to the QRS. And when you put all that together, you can figure out what the rhythm actually is. After figuring out what the rhythm is, you're going to look at the QRS closely itself and figure out what's the axis. Is the R wave progression normal or abnormal? Is there any signs of atrial enlargement or ventricular hypertrophy? And are there any blocks? Next, we're going to look at the Q, the ST segment, and the T waves. And these usually go together. They can indicate similar kinds of pathologies. And we'll talk about what the criteria are for abnormalities later on in this talk. Then look for the QT interval, measure the corrected QT, and report that as well, because that can affect management of many conditions. And it's an important reason we get ECGs even in patients who we don't suspect to have underlying cardiac disease. Finally, as a more advanced topic, we can look at or look specifically for special waves that would indicate specific conditions, which are listed here. Starting off with the rate, there's a few different ways we can use to figure out the rate. One of the most accurate ways is, and it would apply for any rhythm, regardless of whether it's regular or irregular, is since the entire ECG strip measures out 10 seconds, all you need to do is count the number of QRS complexes in the whole strip and then multiply by 6 for 60 seconds, and you'll get your answer. If the rhythm is regular, there's some other tricks you can apply. So, for example, you can just divide 300 by the number of big boxes you see between each QRS. Some people just memorize the sequence of that. So 300 if there's one big box between QRSs, 150 if there's 2, 100 if there's 3, 75 if it's 4, and 60 if it's 5, and so on. But again, it would only apply for regular rhythms. It's important to know the rate as well, because a rate that's significantly more than 220 minus the patient's age is unlikely to be a sinus rhythm. Now let's say you perform an ECG on a patient because they're having palpitations, or you notice that their heart rate is elevated. So you'll order an ECG, you'll go up and see the patient, and when you arrive, the nurse will hand you the ECG and ask you to figure out what's going on. So you look and you'll see, first of all, that the patient actually is having a tachycardic rhythm. The rate is more than 100, so QRSs are appearing on the whole more than closer to each other than 3 big boxes. The next question you're going to ask is the QRS generally looking wide or narrow? And by narrow, we're talking about less than 3 little boxes wide on a standard calibration. And it's wide if it's more than that. If it's narrow, you automatically know that the source of the rhythm is coming from above the ventricles. And in that case, the next question to ask yourself is, does it look regular or irregular? Do the R waves, distance between the R waves seem to be consistent, or is it variable? If it's regular, your differential is now narrowed down to sinus tachycardia, something called AVRT or AVNRT, atrial tachycardia or atrial flutter, and you're going to be looking at the different P wave morphologies or atrial activity and trying vagal maneuvers, which we'll talk about, to try and figure out which one it is. If it's irregular, now your differential's slightly different. It's atrial fibrillation, atrial flutter with variable block, something called multifocal atrial tachycardia or MAT, or any rhythm that is also associated with a advanced heart block, a Mobitz 2 heart block. And in this case, you're going to be, again, trying to look at the atrial activity to figure out which one it is. On the other hand, if you looked at the ECG and you saw wide complex rhythm, now there's 2 possibilities. One, it could still be the source could still be coming from above the ventricles. And cases where this might be happening is if there's an underlying bundle branch block, if the patient's really hyperkalemic, if they have an accessory pathway, like in Wolff-Parkinson-White syndrome, or if they're on certain drugs like class 3 antiarrhythmics or class 1A antiarrhythmics, or if they're having a paced rhythm. If they don't really have any of these, you don't suspect those, then a wide complex tachycardia is ventricular tachycardia until proven otherwise. Now, there are other rules, this is a little more advanced, to try and figure out whether a wide complex tachycardia is more likely to be ventricular tachycardia or a supraventricular tachycardia with aberrancy, and these are called the Brugada criteria. It's not recommended that, especially if a patient's not stable, then that you try to apply these criteria, because missing ventricular tachycardia, not treating it quickly, can really lead to severe negative outcomes for the patient. Now, once you at least have an idea of what rhythms might be going on with the patient, you need to know what to do with them. So once you've identified the tachycardia, you next need to ask yourself, when you see the patient, whether they're stable or unstable. And features that would tell you that the patient's unstable would be they're hypotensive, there's a sudden change in their mental status, they're suddenly acutely short of breath, or they're having an acute onset of typical chest pain. If they're unstable at all for any reason, you'll need to cardiovert them. You'll need to place pads on their chest and give them electricity. And these are the settings for the cardioversion that you'll be using. And if any time you don't feel a pulse or the rhythm is wide and irregular, you'll actually use non-synchronized cardioversion or defibrillation. On the other hand, if the patient's stable, you have time to think. So go back to whether the QRS complex is wide or narrow. Narrow complexes, for the most part, especially if they're regular, you can try vagal maneuvers and see if that's able to break the rhythm. Some options for that would be asking the patient to breathe in deeply and hold their breath. If they're intubated, you can actually do an inspiratory hold on the ventilator. You can also try having them drink a really cold glass of water or splashing cold water on their face. And then there's also carotid massage, which is a little tricky to actually perform. It actually involves putting pressure directly on the carotid sinus for about 10 to 15 seconds. If those don't work, you can always use a really powerful AV blocking agent. It's called adenosine, and you'll have to give it as a really fast IV push. First you start with 6 milligrams, then try 12, and then 12 once more. And if it doesn't break with adenosine, then you can be pretty safely sure that you're not dealing with an AVRT or AVNRT. If you're looking at wide complex rhythms, you almost always have to involve cardiology. They'll most likely direct you to either give amiodarone as a bolus or electrically cardiovert them, but long term they may need an ICD placement or ablation of that ventricular tachycardia. Sinus tachycardia you can usually identify pretty well. Any sinus rhythm should have upright P waves in 2 and 3, and the rate shouldn't be more than 220 minus the patient's age. The reasons people go into sinus tachycardia, usually something outside the heart. So it could be that they're in pain, anxious, they could be just really dehydrated, hypoxic. The sympathetic activity is essentially sky high for some reason, and you have to figure out what that reason is. One of the most concerning reasons is a pulmonary embolism, and it might be one of the only manifestations of a pulmonary embolism. The most important thing to remember is you're going to be looking for the underlying cause and treating that. There's no specific medication you're going to give to treat sinus tachycardia, and you should never just give a beta blocker and in hopes of just trying to slow down the rate, because they could actually be compensating for something, and giving them beta blockers would take away that compensation. Here's an example of a patient in sinus tachycardia. You can see that the R waves are closer to each other than 3 big boxes, which tells you that the rate's already more than 100. You see normal looking P waves in lead 2, they're upright. And the rhythm is narrow complex. See, the QRS here is very narrow and regular. Here's an example when a sinus rhythm can be irregular. It's called sinus arrhythmia, and it's a normal physiologic response, especially in young people. So just with breathing in and out, their heart rate slowly varies over time. And you can tell that it's still sinus because the P waves in lead 2 are upright. They look normal morphology, and all of the P waves look pretty much the same, which tells you that it's most likely coming from the sinus node, but that with variations in the respiration, the distance between the QRS complexes is changing. Okay. Atrial fibrillation, this is another common arrhythmia that we see in our patients. It's irregular, usually narrow complex, and you won't see clear P waves on the ECG. There's multiple mechanisms that would cause atrial fibrillation, but the most important risk factors would be any kind of diseases that would increase left atrial pressure, so like valvular diseases like mitral stenosis, mitral regurgitation, heart failure, or an old infarct. A lot of lung issues commonly lead to triggering atrial fibrillation, including pneumonias, COPD exacerbations, asthma, pulmonary embolism. Hyperthyroidism is one of the most common causes of atrial fibrillation, and it's why we always check TSH levels in these patients. And then drugs, especially stimulant drugs, and that's why we also generally tend to check urine drug screens in our patients who come in with new onset atrial fibrillation. Commonly asked question is the source of atrial fibrillation in most, especially most young patients without any of these risk factors, are the tissue around the left atrium near where the pulmonary veins enter. And that's important because by ablating the tissue around that area, you can sometimes stop their atrial fibrillation. So let's look at an example. This is a patient with a rhythm that's irregular, and it's actually normal rate. So if you count, since it's irregular, you can't use the rule of counting big boxes between each QRS, but you can count the number of QRSs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and multiply by 6. So that gives us a rate of about 66. And you really don't see clear P waves. You may think that these deflections are P waves, but they're just not consistent enough for you to be calling them real P waves. So without evidence of consistent clear P waves and an irregular rhythm, you can diagnose atrial fibrillation. And normally you associate atrial fibrillation with a tachycardia, but in a patient who's rate controlled, maybe on beta blockers or diltiazem long-term, their rate will actually be in the normal range, and that's rate controlled AFib. Atrial flutter is very similar. It's a narrow complex tachycardia, and it can actually be irregular, regular, or completely variable depending on the patient. The most obvious feature in atrial flutter are these sawtooth waves or F waves that you'll see occurring almost about every big box apart. So that's 300 times a second. And the AV node can't conduct that fast, so the ventricular rate will be some fraction of that. So if you have 2-to-1 block, then the ventricular rate will be 150. If you have a 3-to-1 block, it'll be 100. If you have a 4-to-1 block, it'll be 75. And the mechanism of this is actually quite interesting. There's a loop of electrical activity that passes around near the tricuspid valve and the inferior vena cava where it enters the right atrium. And it's useful because an electrophysiologist can actually go in there when they identify a flutter and use a variety of techniques to get rid of that pathway. And if they do that successfully, they can prevent the flutter from returning. Here's an example of atrial flutter from an actual patient, and we typically look in lead 2, and here we see negative deflections. There's one, and they look like they're about one big box apart, which is consistent with flutter because the sinus node can't fire at 300 times a second. And the rhythm overall is pretty regular, so the QRS complexes are about 2 boxes apart, so that gives us a diagnosis of atrial flutter with a 2-to-1 AV block in this case. This is also a patient with atrial flutter, although it's a little more difficult to recognize. So in this case, you don't really see the clear sawtooth pattern in lead 2, but what you will see in V1, which is the other lead where you can look for atrial activity, is you'll see a blip here, a blip here, a blip here, a blip here. And again, these blips are occurring at one big box apart, 300 times a second. The sinus node can't fire that fast, so it's not sinus tachycardia. And it's more consistent with atrial flutter. And so these are called F waves with a capital F. Here's an example of a confusing rhythm. So if you look in lead V1, sometimes you do see sawtooth-looking waves. So around in this stretch here, and in this stretch, a little bit here. So you might be tempted to think of this as a flutter, but given how different those flutter waves look, usually in real flutter, each flutter wave is going to look pretty similar to the other flutter waves in the same strip. So you see them here, but around here they start to kind of degenerate. Here they're not really consistent. And here they're looking like they're degenerating again. So when you see a pattern like this, and again, this rhythm is irregular, this is actually a form of AFib, even though you might think you see some P waves or flutter waves. It's called coarse AFib. Now there's multifocal atrial tachycardia, which is, in addition to variable flutter and atrial fibrillation, is the other possible differential for an irregular rhythm. The key to identifying it is you're going to look for clear P waves, but they're going to have different morphologies alternating with each other. And it's really commonly associated with patients with lung disease, including pneumonias and COPD. Especially during this recent COVID epidemic, we've been seeing a lot of patients with this rhythm because they do have significant underlying structural lung pathology. Here's an example of multifocal atrial tachycardia. You see these arrows here. Each of them are pointing to different P waves. So here you see a P wave that's inverted. Here you see a P wave that's fairly tall but upright. And here you see a short P wave that's upright. So you see, as long as you see at least 3 different morphologies, you can call it multifocal atrial tachycardia. AV nodal reentrant tachycardia is an interesting phenomenon. It occurs when there's 2 different pathways inside the AV node. There's a fast pathway and a slow pathway. And normally when a sinus node impulse comes down, it gets conducted through both these pathways at the same time, but the fast pathway loops around and blocks off the impulse coming down the slow pathway, and only one gets down into the ventricles. So the ECG looks pretty normal, even with the fast and slow pathway present. Where things go wrong is when when in certain situations, electricity starts looping around this circuit, around and around, and each time it loops around, it'll send an impulse up backwards through the atrium and down through the His-Purkinje system into the ventricles. And so, because the speed of this loop is much, much faster than what's usually generated by the sinus node, it's going to cause a tachycardia. You're going to see P waves, but they're going to appear after the QRS complexes because the ventricles get depolarized really quickly through this His-Purkinje system, and then the atria get depolarized backwards, but slowly. So you see here these inverted P waves right after the QRS complex. And most important thing about these is that they break really easily with the vagal maneuvers and adenosine. Something related to AVNRT is AVRT, atrioventricular reciprocating tachycardia, and that occurs in patients with an accessory pathway or Wolff-Parkinson-White syndrome. So you see here a normal patient with Wolff-Parkinson-White syndrome. In addition to these pathways that go into the AV node, they have this extra accessory pathway that bypasses the AV node and goes directly into the ventricles. So because of that, they don't have the slowing down effect that the AV node usually provides, and so there'll be a short P to R interval, as you see there, and there'll be an early slurring of the QRS complex that's caused by early depolarization of this part of the myocardium, and that causes this slurring, which is called a delta wave. Again, this usually isn't much of a problem in general, but just like with the fast and slow pathway in the AV node in AVNRT, sometimes you can get a loop that's formed by this accessory pathway and the His-Purkinje system, and electricity will keep flowing around and around in this loop, causing a tachyarrhythmia. And similarly, in this AVRT, if it goes in this direction, with the ventricles getting depolarized normally through the His-Purkinje system, you get a narrow complex QRS, and then the P wave is inverted and comes after the QRS. So that's what you see here. Narrow QRS, P wave, inverted, and after the QRS. If the electricity is flowing in the opposite direction, that the ventricles get depolarized through the accessory pathway, the QRS is going to be wide with a delta wave, and you may not even see a P wave. And this is a real example of a patient with AVNRT. So if you look in lead V1, you see little blips right immediately after the QRS complex is there. And those are essentially the R waves that are being created by retrograde depolarization of the atria. Here's a common one that will show up on board exams. So here you see a wide complex tachycardia, but it's irregular. So your first impulse in seeing a wide complex tachycardia is that you might be dealing with a ventricular tachycardia, but ventricular tachycardias are usually pretty regular. So if it's irregular like this, you really want to suspect that the patient might have underlying atrial fibrillation, and there's some aberrancy which is leading to this wide complex. And in this case, the cause of the aberrancy is an accessory pathway. So this is essentially atrial fibrillation in a patient with Wolff-Parkinson-White syndrome. And that's really dangerous because normally the AV node blocks a lot of the fast impulses that are caused by the fibrillation. And if you lose that ability of the AV node to suppress those impulses because you have a bypass pathway, it can lead to really, really fast ventricular rates, which is dangerous. So it's really important in these patients not to give them anything that would slow down their AV node any further, because then all of the impulses would go through the accessory pathway and cause the patient to go into VFib. So instead, if you ever see this, you're going to want to give the patients procainamide as your first-line choice of drug. Atrial tachycardia, this is actually similar to multifocal atrial tachycardia, except instead of having multiple P-wave morphologies, you just have one abnormal P-wave morphology. There's either a reentrant pathway or an ectopic pacemaker in the atria that's firing abnormally and causing this rhythm. So in this case, you see P waves before every QRS, but they're inverted, which isn't typical for a sinus rhythm, especially if this is lead 2 that we're talking about. Again, here's an example of what that looks like. Here again, if you look in lead 2, you see inverted P waves, which is not typical for a sinus rhythm. Now, ventricular tachycardias are pretty scary rhythms. They're usually reentrant rhythms caused by scar tissue in damaged myocardium, usually after an infarct. There's two kinds broadly. There's what's called monomorphic ventricular tachycardia, which is what you see up here. All of the QRS complexes you see there are wide, but they all look pretty much the same. Whereas polymorphic VT, which you see here, the QRSs are really wide, but they all look different. Now, if this occurred in the setting of a long QT interval, that's what we'd call torsades. But if it wasn't, if the patient actually had a normal QT at baseline, then you might see this after an acute MI. And it's one of the most dangerous rhythms that tends to lead to sudden cardiac death in those patients. Lastly, with rhythms, we can see occasionally what's called ectopic beats, so QRS complexes that kind of seem out of place. So on top, if we look at this complex here, it seems to have come much earlier than expected for the rate that's going on in these other QRS complexes. And it looks completely different than the others. It's wide, it has a different, it's pointing up instead of down. So the source of this it's coming from the ventricles rather than the sinus node. And so it's called a premature ventricular complex. Sometimes you see a beat that's coming unusually early, right here, but the QRS itself looks pretty similar to the other QRSs that are surrounding it. And you also see here there's a P wave right before the QRS, but it looks slightly different than the other P waves. So this P wave didn't come from the sinus node, it came from a different focus in the atria, and we call that a premature atrial complex. Finally, you can have a beat that's premature but isn't associated with a P wave at all. It's still narrow, looks like the other QRSs, but just doesn't have a P wave associated with it. And that's a premature junctional complex. It comes from an ectopic focus inside the AV node. So moving on to axis. Axis is essentially the main direction that electricity travels when it depolarizes the ventricles. And so if you see here, the sinus node would be sitting around here somewhere, and the ventricles are mostly down and to the left of the AV node. So the major direction of ventricular depolarization is aligning itself mostly with lead 2. And it's also mostly right to left, so it's also aligning with lead 1. And it's also mostly from top to bottom, which is aligning with AVF. So in a normal heart with a normal axis, you should expect to see that the QRS complex in leads 1, 2, and AVF should be all positive. As long as it's positive in 1 and 2, you can be fairly confident that you're dealing with a normal axis. If it's positive in 1 but negative in 2, then your axis is somewhere in this area. That's what we call a left axis deviation. So you see that whenever the bulk of the heart is shifted more in this direction, which is what you might see in when the left ventricle is more hypertrophic, or if the conduction system isn't depolarizing the heart in the normal direction, which you will see in an anterior fascicular block. If you have a negative QRS in lead 1, then things are shifted more on this side, and you can use AVF to determine whether you're in this quadrant or this quadrant. So if AVF is positive, you have a right axis deviation, and if AVF is negative, you have something called an extreme axis deviation. And the causes of either of these conditions would be someone who had severe right ventricular enlargement or hypertrophy, a posterior fascicular block, or a significant myocardial infarction affecting the left side of the heart, which would take away muscle mass on this side and shift things more towards this side. Somewhat related to the axis is the R wave progression. And the concept of this is that the R waves should get taller as you go from V1 through V6, as you see here in this diagram. And that's because the bulk of the heart is actually in the left side, which is overlying the area where V4, V5 are located. So the biggest amount of electricity should be coming around V4, V5, and then coming down. If you don't see that, then you might suspect that the patient had an anterior wall infarct, really low EF, a fascicular block of some kind, or RVH, which would shift everything more to the right. So the R wave in V1 would be much taller than the R wave in V5. Heart blocks are what happen whenever the impulse from the sinus node fires, but for some reason the ventricles either don't get depolarized or get depolarized with a big delay. And usually this happens because of some damage or impairment in the system just around the AV node here. And that's what's called an atrioventricular block. So either there's a delay in the sinus impulses reaching the ventricles, or because of significant damage to these pathways, some of those sinus impulses don't even get conducted at all. A bundle branch block is a problem in either the right bundle or the left bundle. So only one of these pathways is blocked, so the ventricles do get depolarized. There's no dropped QRS complexes, but the QRS morphology will be abnormal because the conduction isn't proceeding through both ventricles simultaneously. One ventricle is getting depolarized early, and that's going to affect the shape of the QRS. We divide AV blocks into first degree, which is the least severe. That's just where there's a greater delay than usual in the sinus impulses getting conducted through to the ventricles, and that'll be seen with a PR interval that's greater than 200 milliseconds. Second degree AV block is where some of the impulses, but not all, are not conducted through to the ventricles. And so you'll see what we call dropped beats. And in that category, we have the Mobitz 1 second degree AV block, where you'll see progressive prolongation of the PR interval until the drop beat occurs. And the Mobitz 2 AV block, where the PR interval stays about the same and there's intermittently dropped beats without any warning. In a third degree AV block, none of the sinus impulses actually get through to the ventricles. So you'll see P waves, but none of those P waves are leading to the QRS. And so there's another pacemaker, either in the AV node or in the ventricles themselves, that's kicking in, and it's responsible for generating the QRS complexes. Here's what they all look like in a rhythm strip. In the first degree AV block, you see that it's a regular rhythm. There's P waves before each of the QRSs, but it looks like there is more than 2 boxes from the start of the P wave to the start of the QRS, more than 200 milliseconds, and that's indicative of a first degree block. In this picture here, you see QRS complexes here, 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 and here, but there's a space here where a QRS should be, but it isn't. So that's what we call a dropped beat. And you see just before that drop beat, there is a P wave. And if you look at the P wave here, there's a fairly short PR interval, which gets longer, 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 until the beat finally drops. And that's what's pretty typical of a Mobitz 1 block. In a Mobitz 2 block, which we see here, the PR interval is about the same with each beat. here, 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 and here. But there is one P wave here that is not associated with a QRS. So fixed PR interval, but occasional drop to beats, P wave without a QRS, that's Mobitz 2 AV block. In the third degree heart block, again, we see P waves here, 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 and here. But there's no clear association between these P waves and the QRS complexes that are surrounding them. So here, this looks like the P wave is just slightly before the QRS complex, but in this case, the P wave is occurring just after the QRS complex. So whenever you see no association between a P wave and a QRS, you should suspect a third degree block. Bundle branch blocks, like I said, will change the morphology of the QRS complex. You're going to look in leads V1 and V2, as well as the lateral leads 1, AVL, V5, and V6. And normally, in a normal patient, you'll see in V1 and V2, you'll see a small R and a big S wave in that lead, and you'll see a small Q and a tall R in the lateral leads. In a right bundle branch, in leads V1 and V2, you'll see two separate R waves separated by an S wave. We call that an R, S, R prime pattern. And in the lateral leads, you'll see a small R with a deep slurred S wave. And that's typical of a right bundle branch block. And what this is really showing you is that the right ventricle since the right bundle branch is blocked, the left ventricle gets depolarized first, and the right ventricle gets depolarized later and slower through direct electrical conduction through the myocardium. And in the leads that point to the left, which are 1 AVL, V5, and V6, the right ventricular depolarization will occur second and slower. In the left bundle branch block, in the lateral leads, we'll see usually two peaks. We'll call it an R prime pattern, and a big negative deflection in leads V1 and V2. Now, fascicular blocks and hemiblocks. So the left bundle branch, shortly after it branches off from the His bundle, it'll branch off itself into a left anterior fascicle and a left posterior fascicle. The anterior fascicle runs anteriorly on the heart and ends up on the lateral wall of the LV, whereas the posterior fascicle runs posteriorly and downwards near and ends up near the septum of the heart. Now, if you imagine blocking the anterior fascicle, only the posterior fascicle is free to depolarize the left ventricle. So it's going to start from here and start depolarizing the ventricle in this direction. And if you think of where the axis of the heart is, instead of depolarizing the heart in this direction, it's mostly getting depolarized in this direction, which corresponds to a left axis deviation, which is one of the biggest features of a left anterior fascicular block. On the other hand, if you block the left posterior fascicle, the left ventricle gets depolarized starting from here, and it spreads down the wall like this, whereas normally the heart would get depolarized like this. This is causing a shift of the axis more to the right. Enlargement of the atrium You're going to look in leads 2 and V1. Normally you see a small positive R wave P wave in lead 2 and a biphasic P wave in lead V1. So it starts to go up and then down. And this represents the right atrial depolarization, and this represents the left atrial depolarization, which occurs just a little bit slower because of that Bachman's bundle. If the right atrium is enlarged, then in lead 2, the whole P wave just gets really tall, and you'll see a P wave that's more than 2.5 little boxes tall. In lead V1, that positive initial part will be much bigger, and the negative part, that left atrial, will be relatively smaller. And generally, my rule is if you can fit one little box underneath that positive part of the wave in lead V1, then you're looking at a right atrial enlargement. And left atrial enlargement, the biggest thing is increase in the width of the QRS complex in lead 2. So if you see a QRS complex greater than 120 milliseconds, 3 little boxes, and with double peaks, then you're looking at a left atrial enlargement. Similarly, in V1, in left atrial enlargement, that second negative part of the P wave, which corresponds to the left atrial depolarization, is much, much bigger, and you can fit at least one little box underneath that curve. Ventricular hypertrophy, for left ventricular hypertrophy, there's a number of complicated criteria that people have come up with to establish that someone has left ventricular hypertrophy, many of which you don't need to memorize, but the general principle is that you'll see really tall R waves in the lateral leads 1, AVL, V5, and V6. And in right ventricular hypertrophy, there aren't very many specifically named criteria for it, but you'll see the opposite changes. You'll see really tall waves in R waves in the leads where pointing near the right ventricle, like leads V1 and V2, as well as right axis deviation. Here are 2 examples of patients with ventricular hypertrophy. In left ventricular hypertrophy, you see really tall R waves in V5 and V6 here, and big S waves in V1, V2, V3. Together with these tall R waves, you'll see ST depressions and T wave inversions in the lateral leads as well. These are normal for LVH, and they're not necessarily indicative of additional ischemia or other pathology. In the patient with right ventricular hypertrophy, the same changes are seen, except you're going to see them in leads V1 and V2. Tall R waves. Usually the R wave in V1 is taller than the R waves in V5 and V6, with ST depressions and T wave inversions there. Moving on to recognizing patterns of myocardial infarction. This is another common reason that we get ECGs in our patients, especially those who present with chest pain. And many times we'll see things that look like ST elevations, but we're not sure whether they're concerning enough to call cardiology or start the patient on medication specifically for a myocardial infarction. And there are these criteria for determining whether ST elevations that you see are significant enough to be concerned. You need to see at least 1 millimeter of ST elevation in most leads, and you need to see it in contiguous leads as well. So if you just see an isolated ST elevation in, let's say, V2 or V3, that's less than 2 millimeters in most patients, that's not usually concerning. In addition to ST elevations, Pathologic Q waves are another sign that a patient may have had significant infarction. Normally, you'll see Q waves in the lateral and inferior leads, and that's just because of the depolarization of the septum. But if you ever see a Q wave that's more than one little box wide or deeper than a quarter of the height of the R wave that's associated with that QRS complex, that's not normal. Also, if you see any Q waves in leads V1 through V4, that's also not normal. And it should make you suspect that there's a septal or anterior wall infarct. Here's just a diagram of the blood supply to the heart. You'll see that there are two arteries that will come out of the coronary cusps, the left main and the right coronary artery. The right coronary artery gives off the blood supply to the the SA node. And that's why lesions in the proximal RCA will lead to patients developing bradycardia. The left main artery branches off into the left anterior descending, or LAD, and the left circumflex. The circumflex usually wraps around to meet the end of the right coronary artery, and depending on whether a patient has a right dominant circulation or left dominant circulation, either the RCA or the circumflex will give off the artery called the posterior descending artery, which supplies the posterior wall of the heart. Meanwhile, the LAD continues on to supply most of the anterior wall of the heart, which does a significant part of the work of contracting the left ventricle. Again, it's very important to keep in mind ECG lead anatomy, because you can really use this to identify the location of the infarct, and many cardiologists will look at the ECG to help identify where they should start looking for a blockage. Here's an example of how to put all this together. This is a patient who came in with typical chest pain and was found to have this ECG on admission. So one of the few things that'll stand out to you is there's a pretty big gap between the QRS complexes in this patient. So if you just count the QRS complexes, there's 1, 2, 3, 4, 5, 6, 7, 8, 9 QRS complexes in this 10-second strip, which gives you a ventricular rate of 54 beats per minute, which is bradycardic. In addition to that, you'll see quite prominent Q waves in leads 2 and AVF. Those are not normal, so that's suggestive of pathology of an relatively older infarct in the inferior wall. And in addition to the Q waves, you also see ST elevations in those same leads, which is more suggestive of a newer infarct. So when you put those things together, you say that there's a not exactly acute, but not entirely just old either, since there are ST elevations. So we'll call this a subacute inferior infarct. In addition to the inferior leads, you also see some interesting involvement in leads V1 and V2. You see these tall R waves and ST depressions in lead 2, and the ST depression in V1. This is also suggestive of involvement of the posterior wall of the heart, as we'll see in a moment. Now, it's important to keep in mind that not every ST elevation necessarily corresponds to acute coronary occlusion. So, in addition to coronary blockages, ST elevations can also be caused by any number of these conditions, and it's important to look at the patient in context to see whether the ST elevation that you're seeing might be due to one of these things rather than a myocardial infarction. We're all trained to be really concerned about patients with bundle branch blocks. I'm sure we've all heard before that new left bundle branch blocks are especially concerning. But if a patient has an old bundle branch block, there are criteria, especially in a left bundle branch block, there's criteria in place to identify whether ST elevations in that setting are concerning or not. And those are called the Scarbosa criteria, and they're listed here. Remember that a new right bundle branch block in the right context, so in a patient with typical chest pain, acute onset crushing, worsened by exertion, that can be just as concerning, if not more, than a new left bundle branch block, because the right bundle is supplied by the proximal branch of the left anterior descending artery, and that's a very serious blockage. Some other patterns you want to watch for that are really concerning and would prompt you to call cardiology for possible urgent catheterization right away. Welland syndrome, there's two forms of this. One you'll see in type B, deep symmetric T wave of inversions in the precordial leads. And type A is where you have a slight ST elevation followed by a kind of biphasic T wave. It goes up and then down. Also in the precordial leads. This isn't indicative of like 100% blockage of the LAD, but it usually indicates that there's dynamic changes going on. So there's the vessel being blocked, reopening again for a little bit, and then blocking off again. So you want to watch these patients very, very closely. If not, take them for left heart cath right away. De Winter's T waves, also a sign of significant LAD occlusion. You'll see deep ST depressions and really tall T waves in the anterior precordial leads. Finally, there's, if you ever see in leads V1 and V2, tall R waves with a deep ST depression and upright T waves, that's telling you that there's a STEMI going on in the posterior wall of the heart. And you can see this for yourself. If you flip this ECG upside down, what you'll actually see is a Q wave followed by an ST elevation and a T wave inversion. So that R wave, that tall R wave, would correspond to a Q wave in any of the other leads, and that ST depression would correspond to an ST elevation. And you're flipping it because V1 is directly opposite to the posterior wall of the heart. If you ever saw this and you wanted to confirm for sure, you can get a posterior side ECG with leads V7, 8, and 9, and you'll see ST elevations in those leads. The QT interval is one of the most important things we look for. We look for this in every patient, regardless of whether they come in with a cardiac condition. It'll affect which antibiotics or antiemetics we can choose to give our patients. So we measure just the uncorrected QT interval from the start of the QRS to the end of the T wave. But we also want to recognize that the different heart rates can also affect how the QT looks. So we do correct the QT interval for the heart rate, and there's various formulas that are listed here that we can use. One of the most common that our ECG machines use is the Bizet formula here, QT divided by the square root of the RR. If you just eyeball the ECG, you'll want to look for a QT interval that's less than half of the RR, and you can see that's the case here. that the QT is less than half of the RR. Whenever we see QT intervals greater than 500, we really start to worry, and we don't give our patients any drugs that would worsen their QT prolongation out of fear of potentially causing torsades. Okay. Now to finish off, we'll talk about two common problems that would appear with ECG manifestations, and getting an ECG would very much affect the management of these patients. One is hyperkalemia. So whenever a patient comes in and you either suspect or find on their blood work that they're hyperkalemic, you'll want to order an ECG right away to look for certain changes. Typically, in textbooks, you'll see them described in a step-by-step sequence, but you have to keep in mind that not every patient necessarily will progress in this order, and they might skip some steps, and there's not always a clear correlation between potassium levels and what ECG changes you should expect, although in general, you usually don't see significant ECG changes until the potassium is greater than 6. The first step in ECG changes that you're going to see are the tenting T waves, and you're going to look for T waves that are consistently more than 10 millimeters in the precordial leads and more than 5 millimeters in the limb leads. As the potassium level goes up from there, you'll see that the P wave starts to disappear and the PR interval gets longer and longer. Then, as the potassium level goes up more, you'll see that the QRS complex itself gets bigger. Remember that hyperkalemia was one of the causes of aberrancy, wide complex. That's not actually a sign of VT. And you'll see ST elevations as well. So remember that hyperkalemia was a cause of ST elevations. And as this continues to progress, the QRS complex and the T wave are sort of just going to merge into one sine wave looking pattern. And that's the most serious sign of ST elevation just before the patient goes, most serious sign of hyperkalemia just before the patient goes into VT. If you see any of these changes, the most important step is, of course, to give a patient calcium, 1 gram of calcium gluconate right away. Now, pulmonary embolism, this isn't a diagnosis that we make using the ECG specifically, but a lot of times finding certain patterns on the ECG can clue us in that the patient might need further evaluation for a PE. And roughly in the order of how often we see things, this is what you're going to be looking for, at least a few of these things that would really clue you into the idea that a patient might have a PE. Most patients just present with a pure sinus tachycardia. A lot of patients who present with new onset atrial fibrillation or flutter also have PEs. You're going to look for a new complete or incomplete right bundle, right axis deviation, T-wave inversions in the anterior or inferior leads, and the much talked about S1, Q3, T3 pattern. So in here, we see a patient, ECG of a patient with very likely to have a PE. And a few of the clues that we're seeing are the RSR prime pattern here in lead V2, which is suggestive of a right bundle branch block. The QRS's complexes are somewhat wide, which would tell you that there's a right bundle. And patient is tachycardic, so you can see that the QRS complexes are slightly less than three big boxes apart. So that's telling you a patient's tachycardic. And we see the S1Q3T3 pattern right here. So there's an prominent S wave in lead 1, prominent Q wave in lead 3, and the T wave is inverted in lead 3. So when we put all those together, that would definitely warrant further investigation for a pulmonary embolism. All right. And that completes my lecture on ECG interpretation. Thank you very much and have a good day.